So, Lahira, thank you for joining us tonight. We've had you before, but it's been a couple of years, I think, and Lahira and I now actually work together. My anaesthetic department's been swallowed up by his anaesthetic department. It's called a voluntary merger. And so I'm one of the team now. And so it was easy to just nudge him and say, hey, Lahira, how about doing this again?
Yeah.
But please introduce yourself, and also feel free to promote your own passion dream project that you've been running.
Yeah. Thanks very much, Greg. And yeah, always happy to speak to you guys. I recently went to work in Broome where there's a lot of GP anaesthetists, and it's just amazing the work that you guys do. So just really, really happy to support this, and just great work with education, and such a great education program that you run, Greg. So yeah, really happy with that. Okay. So look, I actually really like giving these tubes because I try to think of a new way of presenting something each time I give one of these tubes. And so this was trying to give you guys who've now done a few months of anaesthetics, how can you potentially, supersize your approach to your theatre lists and try to make even better plans. So that's hopefully what we'll go through. I want to make this, really informal. So any questions at any time, please write in the chat or just, speak up, unmute yourselves and speak up. I'm really happy to take interruptions. There'll be lots of time for questions as well. As Greg mentioned, I pretty much what I do when I have any spare moment is try to do education. And so my website is anesthesiacollective.com. You can find me on various podcast platforms, and Instagram and TikTok, and I've got a course website here as well with the Anesthesia Foundations course is probably the most relevant to you guys, where I just step through all the beginner stuff that I'd want to know in my first 6 to 12 months of anesthesia. And so that's that. As I mentioned, what I found about doing education online is that when I first started doing videos, it really was just for my own students. But then, the amount of people that get to watch this stuff in other countries that may not have the same level of education is fantastic. And that's why I really appreciate Greg allowing me to record this and putting it up on YouTube, because it's not a confronting thing. It's just me putting some knowledge up, and hopefully the interaction that we do, everyone has these questions, or everyone thinks about things in a different way, and having that discussion is so important when we're trying to educate people who want to learn this stuff. I've got a live series called the ABC's Bootcamp series. If you go to the Anesthesia Collective website, you can see kind of the dates there. I usually line up maybe 2 to 3 hour lectures on a Saturday throughout the year, and all proceeds that roughly $50 to $100 each, and all the income from that goes straight to a charity. Usually Fred Hollows. I'll give you the elements of a basic anesthesia plan, and we'll then go into some advanced stuff. And I'll then try to share with you the high yield elements in various common scenarios. So, the idea is to try and give you a broad scope of stuff that I wish I knew straight away in my first few months, because it's not complicated. You just don't know it until you know it. And so that's kind of the aim of doing this. I really want to get across some subtle things that will make your life a lot easier, and, therefore make your patient a lot safer as well. Let's crack on. So really, I'm hoping that once you see your theatre list or a particular situation, it'll be like reading a crystal ball. And, just doing multiple reps of cases, you'll eventually learn this stuff, regardless, after you do 5 years of anesthesia. And I'm thinking, we can get there a lot sooner through these kind of techniques. So the basics are, first of all, really your anesthetic plan, the kind of the high yield stuff at a basic level is, do I do a general anesthetic, regional anesthetic, local anesthetic, or nothing? Do I use an LMA or an endotracheal tube? And which parts of the anesthesia triad do I need? And usually the decision is for paralysis or not. Most cases, you have some kind of hypnotic agent, propofol or sevoflurane or whatever, and some analgesic like, fentanyl, alfentanil, remifentanil, and whatever other combination. The standard monitoring is almost always applied. Your saturation pressure, your blood pressure, your ECG, and all the gas monitoring stuff. But then the additional stuff that you often have to ask for, therefore make a decision about, is whether you need an arterial line or a CBC or some other fancy monitors. There's a lot of lower stakes monitors like neuromuscular monitors, BIS, temperature monitors. Those are kind of a given. I'm not really going to be talking too much about that, because those aren't often life and death things. We always have to decide on a pain plan for intraoperatively and postoperatively, and we'll go through some high yield stuff about that. And then a postoperative nausea vomiting plan, antibiotics, DVT prophylaxis as well. And then where the patient needs to go afterwards, whether it's a transfer or HDU or ICU. Now, the advanced plans we're going to go through are airway stuff, blood loss stuff, complex pain, complex PONV, PEDS, high yield stuff, and then a couple of inductions, which I think are really relevant. So this is kind of how I approach every general anesthesia. You hear that the triad, it's hypnosis, analgesia, and paralysis, but really there's a whole bunch of other stuff as well. Antibiotics, antiemetics, DVT prophylaxis, and then cardiovascular respiratory support. And really every anesthetic is a balance of a combination of all of these things. And then the one thing that wasn't obvious to me when I started anesthetics was that, essentially the patient wants to be, amnestic. They don't want to remember anything, especially if it's a major operation, and they want to have no pain. The surgeon just needs the patient to be still. So this anesthesia triad is kind of like what the patient needs and what the surgeon needs. Now, the problem is that when you give anesthetic drugs, which are very, very good at getting you asleep, pain-free, and paralyzed, they also stuff up almost every other part of your organ system, or with the life dependent, or the things that really preserve your life. Your airway may obstruct, you'll stop breathing often, your blood pressure drops, your contractility drops. And a lot of our job is providing the cardiovascular respiratory support time and time again after we achieve the triad endpoints. So that's kind of the whole reason why we have a job in anesthesia, is because the stuff that gets you asleep, pain-free, and paralyzed are terribly blunt instruments. They're very good at one thing, and they also stuff everything else up. And that's kind of where our job is all about. And that's also why we get so good at resuscitation, because we're constantly managing these, the ABC things: airway, breathing, and circulation. Feel free to take a screenshot. I'm sure Greg won't mind. This is his checklist. And it might be just really useful to have, especially when you start off, just, these are all the things you could potentially look at. So, that's something just to have a look at, and I guess try to remember, all the different aspects of what your anesthetic case might be. Let's move on. So I might ask my first question. Often the first question after, whether I need a GA, regional, local anesthetic, or nothing, is when do you need paralysis? And first person up, when do you think you need paralysis? And I've already divided it up for you, but surgical reasons, anesthetic reasons, patient reasons. What do you reckon?
Hi, here. My name is Shane. I'm in Albury. Thank you. So surgical reasons. I think the obvious thing is when the surgical team need the patient to be still, or when they need, access to an intracavity site where they need, good muscle relaxation to access the cavity.
And is that all operations? Like surgeons need relative stillness for most operations, like say a hysteroscopy or maybe a fractured GAMP, like general anesthetic manipulation on plaster, or a Colles fracture. So what do you mean by surgical stillness?
I guess I think of things, like neurosurgery or some sorts of microsurgery, I suppose, where the millimeter made a difference.
Absolutely. So you are absolutely right. Most patients, you can get still enough for surgery, accepting ventilation movement, which is predictable, just with big amounts of propofol and analgesics and volatile for maintenance. That is pretty much perfect for most cases. But then for the critically still patient, neurosurgery, microsurgery, you need someone to be absolutely still, no movement at all. And that's when we might paralyze them, plus run remifentanil. Surgical access, you mentioned, is really important. So anything that's intracavity, whether it's laparotomy, laparoscopy, thoracotomy, or whatever it is, having those muscles tensing up really, limits your view into the operation. So that's why you need paralysis for those laparotomy cases. Shane, you're on a roll here. What anesthetic and patient factors might need paralysis?
So I think anesthetic factors, if you decide you need to tube the patient because you're worried about securing their airway, so, if they're not fasted, if they are crumbly, if the operation might be a long one and they might become crumbly.
That's good. So literally the first thing you said there was, I need to put a tube in. So most of the time you need a paralyzed to put a tube in. And that's pretty much true 90% of the time. But I always try to remember that there's plenty of times I don't need paralysis for a tube. You just give a bit more propofol, or they're really deep with anesthetic, or they're a child and they've got weak cords, or they're an elderly patient with weak cords. So, there's almost all the time I'll use paralysis for intubation, but not absolutely always. And crumbly patients need paralysis. Yeah. So specifically, what kind of crumbly patients need paralysis?
I'm thinking of patients where there might be, intraoperative misadventure for whatever reason, surgical or anaesthetic, and you want to optimize your control of the situation. That's what I mean by that, really. Like when it's not clear how things might progress and you want to be as safe as you can.
Yeah, kind of. Actually, I've just added a thing. You're absolutely right. I might actually add something to this slide now, which is, so the one time the patient's disease makes a big difference is if I have the respiratory muscles tight because of bad, obstructive or restrictive lung disease or just severe obesity, paralyzed patient makes ventilation completely much easier than a non-paralyzed patient. But I like what you said, because if I this kind of gets complex, but if I have a patient who's particularly sick from a cardiovascular point of view, if for them to be still enough for the operation, I either have to give lots and lots of hypnotic, or I can give less hypnotic and paralyze them. So you can't right there. The sickest patients, I want to minimize my opioids and my hypnotics. And to do that and still have them not moving for the surgery, I need to paralyze them. So I'm going to add that. That's absolutely a relevant point. And again, any questions about this stuff? I'm not exactly sure of everyone's levels, and tell me if this is completely obvious.
Yeah, most are about 3 months in, but we've got a question from Russell about. You want to ask that, Russell?
Okay. Would you prefer to have some lung disease patients ventilating spontaneously rather than needing IPPV? That is absolutely true. So it would be a case-by-case basis. In the sickest lungs, you'll absolutely have to, because you absolutely have to ventilate, because a patient who's had the anesthetic on board just won't have the muscle ability to overcome the incredible pressures that a sick lung needs to have. So you're absolutely true about mild disease. Sometimes you'll just let them spont vent and it'll be absolutely fine. But in the sickest lungs, you absolutely need to paralyze. That's a really good point. The next person along, how do you decide whether to use a tube or not? What do you reckon? Next person along.
Oh, what's your mood on the day? No, so if there's an indication for paralysis, then they obviously need an endotracheal tube. And if you are going to positively ventilate somebody, you'll obviously have a preference towards an endotracheal tube. Or if they need a secured airway, such as an unfasted patient or an RSI, then again, to just try and protect that airway, you go for an ETT. Whereas if you've got a briefer case or a patient who's able to spontaneously ventilate, well fasted, you may have a preference towards an LMA to let them go through with negative pressure ventilation, not worry so much about that seal.
Hey, so that's good. You mentioned some really good points there. Now, the funny thing is that the Venn diagram of paralysis and endotracheal intubation don't have that much of a crossover. The fact is, the funny thing is, almost all the time we paralyze someone, we also need to put a tube in, but they're often separate reasons. So airway protection aspiration risk, absolutely. Intubation is the gold standard. If you have a shared airway, some of the times you would want a tube in just because there might be gunk kind of falling in from ENT surgery, but plenty of times we do tonsils under LMA. Sometimes you need precise control of ventilation. You wouldn't do the long cases or lung disease cases, neuro cases, very unwell patients with an LMA. But definitely you can positive pressure ventilate with an LMA as well. And the funny thing is, I like this question, because sometimes you get a situation where you have an LMA in and the surgeon for some reason just needs the patient paralyzed or still. It happens often in interventional radiology, or you might have a bladder resection and they just need everything still for a moment, and I've got an LMA in. But when I paralyze them for surgical preference, it doesn't mean that I need to change the tube. And that's one of the things my registrars will often think at the time, oh, we're given paralysis, now we've got to change the tube. But no, as long as you can ventilate appropriately with the LMA, which you've already checked when you started the case, you don't necessarily need to change it. So have a think about it next time you're doing a case. What's my reason for paralysis? And what's my reason for an endotracheal tube? And often there'll be different reasons. The LMA, you're absolutely right, for all other uncomplicated, faster or well patients with no airway issues. How about which monitors do I need? So I'll ask the next person along. Actually, why don't I I'm going to keep going with this. A standard anesthetic requires lots of mandatory and readily available monitors. You don't really have to ask for these. You get the pulse ox, BP, end-tidal CO2, and ECG. And then you have a whole bunch of volatile and pressure monitoring stuff that's all in the machine, and they alarm readily if there's disconnection. The extra monitors, let's say, so you neuromuscular monitor, BIS, and temperature. Don't worry about those. What are the extra kind of monitors that you might want?
So I think it was in one of your initial slides. So arterial line and CVC, depending on the case. I think we've also been doing the Twitter.
Actually, let's go. So forgetting all the other stuff, art line, beautiful. That's the one decision you often have to make. When would you decide on an art line? What are the kind of common reasons?
Yeah. So you consider an art line in a patient that you require frequent gas sampling during the procedure. You would also require in a patient with a major surgery with significant blood loss. And the other one is sort of unwell patients that require vasopressors during the anesthetic or during the surgery. Then you would like to have an art line in.
Yeah, great. And I'll divide those into kind of maybe bigger categories. Anytime you need beat-to-beat monitoring, so imagine an oscillometric blood pressure cuff, it's like cycles every 2.5 minutes or 1 minute. So it's always a retrospective historical measurement. If I want to know the beat-by-beat measurement, because of exactly what you said, they've got some level of cardiac instability, they're a cardiac cripple, I'm expecting massive blood loss, they have massive blood loss, or some other issue, then I'll absolutely put it. And then rapid sampling, absolutely correct. So, imagine the same case, lots of blood loss. I need repeat ABGs and ROTEMs and TEGs and coags for whatever reason. I'm absolutely putting an art line because it's just so much easier to get my results from that. And the final thing is, if it's difficult to measure the blood pressure, and that could be because you've got some weird, pulse pressure variations with atrial fibrillation, or maybe it's just a long operation and you don't want the cuff to be cycling for 12 hours, So yeah, those are absolutely good reasons. And how about a CVC? When would you want to use a CVC?
So I think for CVC would be, I think a few reasons would be if you would like to give multiple vasopressors or multiple drugs, they require bigger lumen. So that's one. Again, a very big procedure that you want good monitoring and easy access, not just IV access, because that sometimes is difficult if their hands are tucked in. I think the ones that I've seen are usually just major procedures like Whipples, long, very unwell patients. You would put one in as well.
Yeah.
Just to give the vasopressors.
That's right. So usually I need to give vasopressors. I need them directly at the heart. I don't want any delay. Absolutely. Sometimes I can't get good vascular access. I recently had to do a cesarean section with a CVC because the patient was, 280 kilos and, any vascular access was going to be tenuous. So absolutely good, solid vascular access. And then there's one thing, and I think someone said in the chat, hepatic, you absolutely need to know your CVC measurement to minimize blood loss in hepatic surgery. And that's really the anesthetic reasons for it. But, you're right to kind of sum up and say, anyone who's sick and often long surgeries, you'll give a CVC because you don't want to be running peripheral NORAD or adrenaline. Yep. I'm going to go through this pain plan. So often, the basic pain plan is that they get a pre-med of maybe paracetamol, maybe ibuprofen, if it's not a kind of a high bleed risk operation. Most people give alfentanil and fentanyl for induction, and then fentanyl or morphine for the operation. And then you can supersize that by giving a whole bunch of other things such as ketamine, pregabalin, lignocaine, magnesium, regional anesthesia. And I can talk about that briefly in a second. In the post-anesthetic care unit or recovery, often we're giving fentanyl or morphine. And then on the ward, acute pain service involvement, PCAs, regional infusions, and ketamine are the common things. And I thought it'd be kind of worthwhile just to give you, again, depending on the centers you work, you will follow the center's protocols, but it's kind of nice to know what you'd run. So if you want to take a screenshot of it as your first, or one of your first recipe lists, it's pretty easy. Most times it's 20 micrograms of fentanyl every 5 minutes, or morphine 1 milligram every 5 minutes. And you can vary a little bit from that, but that's kind of the standard that most places have. Ketamine is roughly 0.05 to 0.2 milligrams per kilogram per hour, which often means around 4 to 16 milligrams per hour in an average kind of 80 kilo person. You may even find yourself doing regional catheters. And oxycodone is good too, absolutely. So I'd dose it exactly the same as morphine, oxycodone. Regional catheter infusions can be really variable depending on the center, but just remember that roughly 3 milligrams per kilogram every 6 hours is with a low concentration is reasonably safe, as long as they don't have liver or hepatic impairment or renal impairment. So it's pretty easy to run 5 mils an hour as a regional catheter with 5 mil bolus. You don't have to remember this stuff. Take a screenshot, load it up on your notes, and then you can always bring it out if you absolutely need it. And then finally, does this patient need HDU ICU? Really the reasons are ongoing airway breathing, circulation support. Maybe they've got a decreased GCS that continues, or maybe they've got other complex organ failure, complex pain issues, complex coexisting disease, or complex nursing requirements. Hey, so I thought we'd just run through very quickly making basic anesthetic plans using that system. I don't know if everyone wants to take a photo or a screenshot of this slide here, and just kind of to go through. Okay, let's after you've done that, let's head to some scenarios, and we're going to start out pretty easy. Let's go with Fraser. Fraser, you're going to get 2 because it's going to be too easy. Okay, make an anesthetic plan for these cases. 40-year-old male for a gastroscopy who's got a bit of hypertension. What are your options?
So I guess you could either do a general anesthetic or sedation.
What would you do for that patient?
I'd give this person what I would call sedation, but I guess is technically probably a general anesthetic without a tube.
Then let's call it sedation and pretend it's that. Yep, good. Nice.
Yeah. So I think I had a similar question last week, but if he was sick or I was worried about he was going to start bleeding out of his stomach, then I'd be thinking about a tube.
Yeah,
I think this is appropriate for sedation. Which components of the triad? I think he clearly needs hypnosis. Mm-hmm. He doesn't need paralysis, and I guess I've seen a lot of particularly alfentanil used in these situations. So I think that's more to sort of obtund their sort of airway reflexes as they're going through, more than for analgesia. For this, I'd use high flow nasal prongs, just as the first 3 of the monitors. He's not going to need anything postoperatively apart from, if he's had a lower scope, he's had some hemorrhoids banded, perhaps I'd have some fentanyl on there, or if he's had an esophageal stricture expanded, perhaps I'd give him a fentanyl pain protocol. But other than that, maybe just some paracetamol and an oxycodone. And post-op care, hopefully he's not heading to HDU ICU. So I certainly would be booking a bed.
That's all good. So yeah, you see the gastroscopy list. Literally, you're just drawing up propafols and maybe fentanyls. And everyone's got their different plan. You can literally do it almost any way. I'm pretty sure in many countries they do it without any sedation and spray to the throat. So you can really do anything. In terms of experience, just really have a plan that you use most of the time, whether you choose fentanyl and propofol or midaz propofol or just propofol, whatever. I find that I get so many sick 90-year-old patients in my center that I end up often using midaz just so I don't have to give as much propofol. And I like that you mentioned high flow nasal oxygen, because that's been a game changer for having just less hypoxemic episodes, even though they're transient. So yep, that's exactly what I've said. How about this one? 35-year-old male, inguinal hernia repair, active reflux. What would you do?
Is this open or laparoscopic?
This is just open repair.
Open. And that's his only medical condition?
Yep.
Yeah, so he's getting I'd probably do a GA for him.
Yep.
In terms of I'm just going to open up your little thing again. In terms of an airway, he's got a history. He's got active reflux, and I think that worries me. So I'd probably use an ETT for this case.
Yep.
Just to reduce the risk of aspiration and a rapid sequence induction.
And just a quick question: so you absolutely agree you need a tube to protect against aspiration. Do you need paralysis? You need paralysis for the tube. Do you need paralysis for the surgery?
I haven't seen that many hernia repairs. I'm not actually sure. I suspect for an open one, no.
Yeah, you don't. It's low. It's low enough that the muscles aren't contracting around it, and they're very retractable. It's not intracavity. So you're absolutely right. Your gut feeling was right. You don't need to give paralysis for these, and often they're done on an LMA. Plenty of people do it with a tube and paralysis, but you definitely don't need to.
Yeah.
Keep going.
Monitoring, he's a 35-year-old whose only medical condition is reflux. So I think just the standard compulsory ones I'm happy with.
Keep going.
I with pain, I guess it's going to be quite a painful procedure. So I want to, I guess, I haven't seen too many of these, but I suspect
it's not too painful.
So I guess he probably doesn't need APS or a PCA. I'd make sure the surgeons had infiltrated it well with local. I don't think it's really amenable to a catheter. So I'd probably have him on oral analgesia post-operatively.
Beautiful. And so just to summarize, you got all the high points there.
Yeah.
You need the full triad. You need the ETT just for reflux, monitoring standard, pain, fentanyl, morphine, multimodal, very standard afterwards. And this goes straight to the ward. That was really great. How about this one? Well-controlled asthma lap collie. Who's next?
Sam Walker.
Okay, Sam, just follow the format.
Yeah, lovely. I'll give it a go. I'd be doing a GA for this patient, and I think they should also have an ETT because you'll be insufflating the abdomen, and also cholecystectomies. You want to make sure that they don't get aspiration as well because they're more of an aspiration risk. More head up, so you don't have that sort of side of things, but it's not as well. You can get aspiration from stomach contents. I want kind of all of it. I want paralysis for the tube and for the surgery. I want hypnosis and analgesia as well. Monitoring, I think if they've got well-controlled asthma, I'd be using sort of the normal SATs, and I'd also be looking out for their airway pressures and waveforms to make sure that to look out for bronchospasm and things like that. I don't think that they really need an art line or a CVC or anything extra.
Perfect. Hey, so that's really good. I totally agree. There's absolutely standard lap collie, and it's good you mentioned paralysis. There's always liquid in the stomach, and increased pressure in the abdomen means that there's this increased risk of aspiration. And also the fact that you've got a pneumoperitoneum means to ventilate against that extra pressure, you need a tube generally to be able to do that. Hey, that's a pretty easy one. Tell me about this one, Sam. 65-year-old male, revision total knee replacement, hypertension, cholesterol, STEMI 1 year ago, aortic stenosis. So it's only a bit of a sicker patient.
Yeah.
What are you thinking?
So wanting to make sure that in terms of this STEMI a year ago, that they're no longer having to be on their DAPT and they can be stepped down to a single antiplatelet agent. I would be wanting to do a spinal and sedation. I wouldn't want to be having to tube this person, and I'd also probably be thinking maybe I want an art line to make sure I'm watching their blood pressure with the spinal, whether that can drop off their blood pressure. And aortic stenosis, I really don't want to drop off their preload.
Good. Hey, and a quick question: with this patient, so do you need paralysis for this or not?
No, I wouldn't paralyze someone.
Beautiful. Do you want to? And you said you want to do a spinal for this. Now, you're definitely not wrong to ask for a spinal. There's the first thing is aortic stenosis. I haven't told you how bad it is, but there's a culture in Australian anesthesia that we don't do spinals, or we resist that for aortic stenosis because that does drop your sympathetic tone so much. I don't particularly agree with that. I think you can do a very preload reducing and afterload reducing general anesthetic as well as a spinal anesthetic, and you just need to titrate it very carefully depending how severe the aortic stenosis is. But there is one point about this case. It's a revision total knee. What do you reckon about that for your decision to do a spinal or a GA?
Well, actually, it'd probably be longer. So potentially the spinal could be wearing off by the time they're finished actually doing the prosthesis.
Exactly. Yeah, that's absolutely right. And revisions, and hopefully you don't have to do too many because there's such long cases with so much blood loss that this becomes absolutely a GA because it's just so horrendously long. Any kind of revision case just becomes a nightmare of cemented metal being taken out and then replaced. It's just horrendous. But I like your thought process. GA for spinal could be high risk, but also the length of the surgery. Really, you just need hypnosis and analgesia. But because it's a long case, you'll probably put an ETT in. And therefore need some paralysis. And when that wears off, you just let it wear off. Art line, absolutely, because you've got the long case plus the aortic stenosis. We'll go through that in a next section. What do you think of the pain plan? Have you done many of these?
No, knee replacements, but not a revision. And also, I think I'm in Warragul, so we don't have a HD. We've got a HDU, but no ICU. I don't know that this patient would actually get done in Warragul.
No, right.
That would be if I saw this patient in PAC, I'd be like, no. But I think in terms of the only other things we've been doing for knees was adductor canal blocks as well. So whether we could do that pre and then make sure there's enough local infiltrated, and I would wonder whether they potentially would need either a catheter or some extra pain relief afterwards as well, because if it's longer, then I'd be wanting to get them mobilizing as soon as possible.
That's really good. So imagine this is not the revision one with the aortic stenosis. They all need some kind of pain plans. You're absolutely right. The easy answer is do whatever your hospital says, because they generally will have some kind of pain plan for knees. And often it may be anything from PCAs postoperatively to adductor canal blocks and catheters, or the ERAS technique with LIA, local infiltrative analgesia. So whatever your hospital system or bundle of care is, you do that, but it can be a massive range of things, knowing that this can be quite a painful operation. I've seen an adductor canal block for internal knee replacement. Could this be done to reduce anesthetic requirement in this sort of case? Oh, look, maybe it's less about reducing anesthetic requirement, but yeah, I mean, absolutely. If you, by the time you give that much analgesia with a GA, it probably is kind of just, it's not a massive decrement to the analgesia that you give, but absolutely, if you do, I mean, you can do this whole procedure with a triple, femoral nerve obturator and a sciatic nerve block, but that's just not done very often when you can just do a spinal or a GA with a few other things. Now this one, I'm trying to think of those cases that sometimes you'll get a case in a rural center that you just have to crack on with. And maybe you don't have time to transfer, they're so sick. What do you think of this one, next person along? Just going through the plan, you're forced into this case, you'd absolutely get help. You'd absolutely maybe call your mates from another hospital and maybe even get you'd be trying to plan a transfer if you're in a small center. But let's say you're forced to theatre. What's your anesthetic plan, next person?
Hi, Larry. So obviously a very sick, basic 4 or 5-ish patient. If I go to the format-wise, I think it has to be general anesthetics. So airway-wise, it's going to be an ETT, possibly an RSI. If they have an NG, suck the NG, get it ready for RSI. So triad-wise, it's paralysis. So something like something for RSI and then for ongoing paralysis. Monitoring, definitely worth having an outline, and possibly a CVC on this case, because this patient will need some presses, possibly something like NORAD to start with. So pre-induction CVC and outline, and possibly start on whatever NORAD or keep your metronome handy. And then pain-wise. Pain-wise. You need some long-acting opioids, some morphine or oxycodone, and then possibly some tap blocks, depending on where the incision is, or tap catheters, possibly. And then post-operatively, if we have the tap catheters, we can go ahead and the patient is extubated and sort of able to use a PCA, possibly, depending, probably have some renal impairment, so adjusting doses and such. And PONV plans, so introp, sort of can use some ondansetron, Maxilon.
Have a post-operative destination where they're going.
Oh, yeah. So depending on how the surgery goes and how the patient behaves, I guess. So if the patient can be extubated, if the hemodynamics picks up, and if they're able to sort of, probably depending on, severe COPD, I don't think this patient can be off extubated, because if they have midline incision, they probably won't be able to sort of take those deep breaths. And
regardless of all of that, where are they going?
I see.
Beautiful. Yeah, absolutely. There's a whole range of what might happen and how bad the disease is. And at the end of the day, you need HDU, ICU. So yeah, absolutely right about thinking about all those things that you mentioned. So this is kind of the tough case. You just have to have, all of these things going: GA, the full triad, definitely an ETG, standard plus outline. I often put a CVC, run aramine and ephedrine in the peripheral line, maybe NORAD dilute in the peripheral line, and then put a CVC once they're asleep. But yeah, if you can do it and if you can get it in beforehand without delaying surgery, absolutely. And then often I'll run fentanyl and ketamine for the case because they're going to be in a lot of pain. And absolutely, post-op care ICU or HDU, depending on how bad they are. How about this one? Tonsillectomy, Crohn's disease, stable and well currently. What's your anesthetic plan? Next person.
Well, tonsillectomy, I think I would use GA. Potentially an LMA with flexi should be okay, but otherwise, maybe intubation depends on what surgeons want.
Mm-hmm.
So definitely this hypnosis and analgesia. Paralysis probably not as important in this case. Airway, so yeah, airway I've already mentioned. Monitoring, I think just standard would be fine for if it's standard tonsillectomy. I don't expect anything that I need to worry about the Crohn's disease. Otherwise, post-op care should be some same days discharge, hopefully. Otherwise, if there's pain, maybe stay 1 or 2 days in the ward.
Yeah, that's all good. So yeah, and this really depends on the surgeon. Some surgeons are totally happy with the LMA. They just work around it. Others need an ETT, therefore you need paralysis to put the tube in often. Standard monitoring, fentanyl, morphine, multimodal. Most surgeons are happy with celecoxib, Celebrex, because it can be quite painful afterwards, and just ward care post-op. Sometimes they can absolutely be discharged that day as well. Hey, so is there anything you would do differently for a FES operation, functional endoscopic sinus surgery? Is there any other things that you have to think about in that type of operation?
Sorry, what's FES again?
If they do, it's like ENT surgery. They're operating through a scope in the nose, doing various resections of the turbinates or other structures.
I guess potentially the bleeding will be more severe, and the tube is probably more appropriate for that.
Yeah, absolutely. You put a tube in often, and you put a throat pack, as someone absolutely correctly said in the chat. Throat pack just mops up a lot of the gunk that falls down. And the other thing is, you're right, there is more bleeding in those surgeries. So often the surgeons really want you to run propofol and Remy. And so again, if you ever see these operations, that's kind of the package of care. You have someone said South Ray tube, absolutely, it gets it out of the way, or a flexi tube, Remy, fentanyl, Antiva running, or TCI propofol running, and a throat pack. That's kind of the extra stuff you do for that particular kind of case.
Lahira, I was just wondering, you've got monitoring, and another level might be other equipment to think about as a trigger. So throat pack might be that, a head ring, a bariatric sort of shaped pillow, other equipment that's not normally there. How about a wedge, for a seizure? Yeah. They're all things that, you can have in your checklist and remember, this is what I need.
No, absolutely. Having an other category, there's so much variability in each of the cases. So yeah, no, absolutely right. Hey, so that was kind of the basics of an anesthetic plan. Often when my trainees come to me, if they just say this stuff at the start, then we can move on from there and get more advanced later. But I thought we would now go through a few advanced plans. And again, I'm trying to make this in the context of GP anesthetics. But the fact is that you will come up with certain emergency things that you may need to do. And you'll definitely be getting experience going into tertiary centers to do work and get upskilling, and then going out into your other centers where GPAs are working, maybe doing more of the general stuff. So let's go through some of these. So let's say for an airway, you've got a 20-year-old for urgent surgery with a foreign body in the trachea. They just don't have time to transfer this, and now the surgeons want you to help them with the anesthetic. And let's say you've got enough support, it's safe to be done. There's a couple of you working together, and maybe you're working with an experienced colleague who's done a few of these kind of things before. What's your method for doing this? I might get a volunteer for this. What would be your method for this kind of operation? Again, a safe place, have a go. Think from first principles. I don't care at all if you get it wrong, because it'll be talking through for everyone to understand what this particular surgery needs.
I'll volunteer. So A 20-year-old with a foreign body and trachea, that has me very worried to begin with. So if any sort of maneuvers to clear the foreign body were not possible, I'd be wanting to adequately pre-oxygenate this patient, potentially consider a surgical airway and get set up for something like that. I mean, I'd be worried about intubation attempts from the top, pushing the foreign body further down, then causing a problem with aspiration. So in my head, I'm just thinking surgical airway.
So Tim, you're absolutely right, because right now you got this thing where the surgeons are going in, and you absolutely highlight the point that sometimes you may not need a tube. So there's two basic ways of doing this, and often it's either an open technique or a closed technique, because you can't often ventilate down there. Have you a closed technique is kind of the familiar stuff, which is like various kinds of tubes. Have you seen any of the various kinds of ENT tubes by any chance?
Not really. I'm not entirely sure what you mean by that, I guess.
No, that's right. And so the best thing is that you mentioned exactly the points that make this kind of case difficult. And then now the solutions are often like, when I first did this, literally I was like, hey, surgeon, what do you need? And the surgeon mentioned something. I'm like, I've actually never heard of that. And then they proceed to show me how it's used. So this is kind of the conversation that I had as a registrar back in the day. So open techniques are either, this literally happens where you might be running propofol, Tiva, and remifentanil to keep the patient nice and still. And then you ventilate them and give them lots of oxygen. And then the surgeon goes in and you step back. You might have Optiflow Thrive now, just to make sure that they're not desaturating. But back in the day before we had that, we'd literally just go surgeon. Okay, so that's 80%. Get back in, bag them up again. Surgeon has a go. Then you have a go. Not ideal, but that's kind of one of the methods. And then you've got these fancy jet ventilation techniques. And the other way is really the preference. You want a tiny tube that doesn't get in the way like a standard tube. And so you ask for an MLT. You place this just like a standard tube, but it's extremely tiny, long, and doesn't get in the way. So really what you're trying to do is somehow give the surgeons more exposure while still enabling yourself to oxygenate and ventilate the patient safely. I thought I might just show you what it is, because it's actually not too difficult a technique. Let's say you get the patient asleep and you can bag mask them. So you know that this patient is safe. You can put an LMA, worst case scenario, you can bag mask them and you can probably put a tube in. So you've got this level of understanding that there's safety if things go wrong. But now the surgeon's got to get in there with some instruments and they're going to get in your way. So they chuck in this device that you'll often see for tonsillectomy cases, opens up the mouth, gives a massive aperture into the oral cavity. And then they've got this jet ventilator needle, and you literally just do short jets of a couple of seconds, watch the chest rise and fall, and then it falls down. And you make sure you're not getting barotrauma, and you just see that rise and fall of the chest and make sure that the chest deflates again. So that's kind of the suspension laryngoscope. So you're jet ventilating from above the cords. And the next most common thing is jet ventilating through the cords. And this is a Hunsaker tube. So literally you attach a jet ventilator here at point number 2. First of all, you just use a normal laryngoscope and you insert this. So the green fronds are past the cord and they just sit in the middle. But these little frond things allow it to sit in the middle and not touch the edge of the trachea. You attach a jet ventilator up to number 2. You put an end-tidal CO2 to number 3. And now you literally just jet 2 seconds at a time, ensuring that you go rise and fall of the chest. Again, once you know that you can ventilate a patient safely, this isn't the most complicated technique, but just to know that it's out there, and hopefully, you don't have to, hopefully no one comes to you in this urgent situation, but this is kind of what you have to do. This is a microlaryngeal tube versus a standard tube. So the micro tubes, that's a size 7 standard. This is a size 5. And this is a size 5 MLT. It's just a longer tube, and it just allows you to, have more space around the trachea for the surgeon to operate. And if they really want to do laser stuff, you get a special laser flex tube. Don't worry about that. This is more for your situation where you might have a foreign body And these are kind of the points of difference. Any questions about that before we move on? I encourage you to all, like when you're doing your rotations and learning your anesthesia, doesn't matter what the case is, ask to use propofol TCI, ask to use remifentanil, because you piece these things together separately. Like you may have never done an open airway technique, but you've done lots of Remi, TCI, propofol. Therefore you've mastered that technique. You know how to run your agents like that. And the next step is something still pretty familiar. Let's talk about blood loss. So an urgent cesarean case with a risk of bleeding. Now, the next question I was going to ask, hey, Tim, you did so well at the other one. Do you want to have more of a go at this one as well? Have you done many Caesars before?
Yeah, I've done a fair few.
Yeah, good. What for you makes a cesarean a high bleed risk?
So it depends on a lot of maternal and baby factors, I would probably say. So maternal, if they had an underlying clotting disorder, and if they had multiple past bleeds, that can put them at higher risk if they'd were multi-paras as well. And in terms of baby, sometimes if the baby is much larger, that can increase the bleeding risk as well. I'm out at this point.
No, that's great. So first of all, I think you pretty much got it pretty much right there. So coagulopathy, absolutely large baby, often gestational diabetes, and number of deliveries. Now, what I didn't put is past history of bleeding. That's absolutely one of them, I should add. Now, the pathology, there's a couple of things on what do you make of the placenta? What makes a placenta risky?
Yeah, so attachment of the placenta into the uterine lining can increase the risk of bleeding quite significantly. So we're talking about placenta accreta, percreta, and increta. That's terms used to describe how far into the uterine wall the placenta is torn. It can often go into a previous cesarean scar as well. So that's also worth acknowledging as well.
That's fantastic. So the thing that I didn't know early in my years of training, which, once you start studying for your second part exam, suddenly this all becomes a big deal. And I've got in the chat, anterior low-lying in a repeat Caesar. Absolutely. So placenta previa doesn't have to be anterior, but it's attached to the lower contractile segment of the uterus, which means that whether it's, as long as it's previa, they will bleed a bit more. So what I do, I upscale by maybe putting a couple of drips in and making sure there's blood ready. Now, if I've got an anterior placenta previa, now the surgeons are going to have to go through the placenta to get to the baby. So they're cutting through the placenta. That's the next level of risk. Now, anterior with multiple Caesars means that now you've got a placenta overlying a cesarean scar, which means it's at some ridiculously exponential increased rate of adhesive placental disorders that Tim was rightly talking about, which is placenta accreta, increta, and percreta. The escalation is like if you have one previous Caesar and an anterior placenta previa, it's like a 10% risk of accreta, and then 20%, then 40%, then 50%. So this is crazy sinusoidal kind of exponential increase in your risk of this badness. And so again, if you're in that center and you see this and you're in a smaller center without backup, without a blood bank, without all the other stuff, you are definitely pausing. You're definitely going, hey, we need to stop this and sort something out. So that's the first thing. Preoperatively, the high points, the points of difference that make me really worried. And now, maybe next person along, if I can't help it, this is an urgent cesarean case, and you're in a center, whatever the center is, you've got no choice but to, go in and get this baby out, and the patient starts to bleed. How do you prepare for this? Go for it. Whoever's next.
So I think the first thing is you need to make sure that you've got a group and hold, and probably need to call your pathology lab and see what products we have on site.
Yep.
And make sure that there's, if there's, I guess the main thing is whether the mother has antibodies. And then...
and just quickly, if people don't know this, again, I feel like I learned this way later than I should have. If someone has, they could have a cross match and it could all be valid, but if they've got antibodies, it can delay your blood delivery from anywhere from 2 hours to days, depending on where you are, because those minor antibodies really, really affect your ability to get cross-match blood. So that's really important that you always check that. Keep going.
And then depending on kind of your site, whether you have the products for massive transfusion protocols. So some places don't have fresh frozen plasma or platelets. So seeing what you have available, then making sure you have adequate IV access.
Yep. And you're saying all these really good things. Let's coordinate a bit. What extra monitoring would you want for this?
Monitoring. So potentially, this is when you think about getting an art line.
Perfect. What extra equipment might you need during this case? No, it's all good.
Yeah.
Yeah, so you're absolutely right. So first of all, the worst kind of blood loss cases, I go straight with a GA often instead of a spinal because, you end up having to convert and then, getting more control and less variability is a big deal. Have lots of help ready, IV access, art line, maybe even CVC for inotropes. Often having two surgeons is a really important thing just to be able to speed up whatever you're doing, and having someone that really knows what they're doing to assist and give confidence and, press on the correct artery and vasopressors ready. Then I think of blood stuff and coagulopathy management. And this is where you really want your friendly hematologist on call. And you can always call someone from some hospital somewhere. So imagine you guys are out in a peripheral center, you know that you can always call someone at some major hospital and they will help. They will take the call and they'll answer and they'll give you help. So blood stuff, I just think of all the products, fluid warmers, a level 1 or a Belmont system, and having a cell saver or perfusionist. And that's often something you can call for from any site, but if you're peripheral, it's, you have to plan way beforehand. And then coagulopathy management, which means, getting the art line for regular ABG analysis, TEG and ROTEM, factor, and hematology support. It gets, essentially once I've got those things ready, it's a lot of stuff, but really it's grouped together and it's just something you have to prepare for. And imagine that situation where you're in a small hospital, but the patient comes down and you got no choice but to go ahead. This is the stuff that will, really save lives. Again, I'm trying to go through just like these high yield points for each case. Let's go to a complex pain patient. So imagine you get a 100 kilo 30-year-old for emergency appendicitis. So again, you've got to crack on with this one. You can't really have time to transfer, but they're on 100 milligrams of endone daily for back pain. Completely inappropriate pain management for this. And in 8 out of 10 pain constantly. What's your anesthetic plan? Does someone want to kind of have a go through talking about the anesthetic plan for this appendicitis?
Yeah, so this complex pain patient, or his opioid tolerance, so you want to consider opioid-sparing medication in addition to, say if you use fentanyl or alfentanil for induction. So starting from basic plan, so this guy will need a GA because it's an emergency appendicitis, so he might not be fasted. So you might want to do a modified RSI and RSI. And then he will need an ETT. Then talking about the triad, so I think he will need hypnosis and analgesia. Ideally, he would need paralysis as well.
Let's go straight to the pain plan. Let's say the pain plan is definitely going to be the point of difference here. Everything else is pretty standard. What extra things would you need to do for this for intraoperative and then post-operative pain? Yeah,
so in a young guy like this, you could consider intraoperative ketamine, boluses of ketamine for him. The other medication that I've used recently is clonidine, so that is a good analgesic and also is good for sedation. And then post-op, it would be good to either use a PCA. Actually, not a PCA. It would be good to use a ketamine infusion post-op because a morphine or fentanyl PCA, he might require lots of them because of his opioid tolerance.
Yep. And now so I actually like the fact that you've mentioned the extra agents because you absolutely have to use ketamine for this case. Like there's almost no situation where you would not use ketamine. Again, it's extremely safe, easy to run, and you just need the appropriate monitoring afterwards. So in a smaller hospital, you'd have some kind of higher level ward or something. What kind of opioids would you need to give intraoperatively? Like how much do you think you'd give for a 1 hour appendix case in this patient?
Good question. Definitely a fentanyl bomb. So 500 micrograms of fentanyl, and I'll just bolus it according to his blood pressure, rest rate, and heart rate. I think it really depends, but usually induction
They're
is one.
paralyzed, so you'll be ventilating, so you won't know what their titrated respirator is because you're doing it for them. But you're right. You would give them a massive amount of opioids. So I absolutely agree. So let's move on from that. Let's say, so multimodal analgesia is absolutely higher doses intraop. So anywhere from 500 micrograms of fentanyl intraoperatively to 20 milligrams of morphine, whatever you choose. And you'd have massive amounts of opioids. You need to absolutely continue their normal opioid requirement and then add whatever thing. Like often they talk about the breakthrough endone being like maybe 10 to 20 milligrams. It feels odd prescribing that, but because that you almost always have to have these patients in a HDU setting so you can monitor these crazy PCA boluses or these endone boluses. Ketamine, again, high dose infusions, I'd easily give 100 milligrams followed by a 20 milligram per hour intraoperative infusion, and then maybe 20 to 40 milligrams an hour infusion post-op. You might want a lignocaine infusion. Again, these are really safe and easy to run. 1 milligram per kilogram and then 1 milligram per kilogram per hour. Again, feel free to take a screenshot of this just as a protocol. As you're doing this emergency case, you'll absolutely be calling your referral hospital and saying, "Hey, we got this really tricky pain patient. What do you reckon?" And yeah, absolutely, these will be things that you can use. And I might even, like you mentioned, clonidine and pregabalin. These don't save the day, but they might just add that extra little bit to really help with any kind of chronic pain issues. And the one thing that you might want to do, and you may, again, it's pretty easy to learn. A lot of the GPAs I know are very good at doing regional blocks, as well as, obviously epidurals and regional techniques. Sometimes if this patient is that patient, you just cannot get rid of their pain, you may need to run an epidural or some kind of other technique for a period of a few days, which I think is completely reasonable for patient safety, as well as just getting rid of excruciating pain, because this patient is highly likely to be in that. Yeah, so lignocaine work for pain IV? Absolutely does. There's really quite good evidence. There's a whole acute pain medicine scientific evidence book that shows how it works for specific kinds of surgery, especially I think mastectomies, and I forget the exact surgeries, but I'd say in those patients at a higher risk of pain, I would almost always run ketamine as my first preference and maybe add lignocaine depending. In terms of a local effect, look, I'm actually not sure. I just assume it's diffusing into the effect site. Would you be reluctant to do an epidural in a chronic back pain patient? That's a really good question. I mean, it depends what the chronic back pain was from. If it's an anatomical problem, if there's nerve damage associated with it, generally speaking, people are a bit reluctant. But I know that epidurals are incredibly safe. If anatomically the space is still available to me, I wouldn't do it to treat chronic back pain necessarily. That's the difference. So maybe this patient had other pain and chronic back pain. If there was two things happening, I would use it, but not just to treat chronic back pain. And then obviously set expectations early, because pain patients, you can never get them absolutely comfortable. And yeah, it's one of those really heartbreaking things to see them in that kind of pain. Now, actually, we've kind of gone, this is probably something that's pretty common, but let's say you get this 30-year-old female, previous PONV for 48 hours after hysteroscopy. Your anesthesia plan would be a standard hysteroscopy plan. Actually, does anyone, say you get the worst PONV patient, what's your kind of supersized plan for PONV prophylaxis?
Anyone want to?
I'll use TIVA.
Absolutely. So you use TIVA. What else? Now, TIVA's maximum effect is roughly that of giving one antiemetic. Hit all the receptors? Absolutely. What other things would you give?
I think like a triple antiemetic plan and then an extra one for rescue in the PACU would be my plan. So some sort of citron, some sort of steroid usually. The TIVA would be one. And then you've still got an antihistamine or droperidol as your rescue options, is what my approach would be.
Beautiful. And I've got to say, for this case, 48 hours of PONV is like absolutely ridiculous, right? So I would actually just go for a spinal anesthetic first of all, over a general anesthetic. Just avoid, giving anything gas related, avoid giving any kind of opioids in that immediate period. So spinal works for me. And often they won't need anything afterwards except multimodal non-opioid analgesia. If you're forced to do a GA, absolutely what you guys said, it'll be an LMA, it'll be 3 antiemetics and running TIVA and minimize opioids by giving ketamine and other multimodal things. I'm just giving you the worst case scenario. I've had patients who have been nauseous, had a history of nausea for 24 hours after an operation, but 48 hours is just incredibly terrible.
A couple of soft skills just to mention here too. When you're wheeling out the patient, to wheel them slowly around the corners. Don't cause extra with motion sickness. Careful with the words you use in recovery. So you say how well they went. You use the special recipe specifically designed for them. It's not a standard. They often think, if they know they've had something special. You
give them the Ferrari of all anesthetics, or pick your special thing. I'd give bupivacaine spinal anesthetic with no opioids at all, so no fentanyl, no morphine, just not necessary at all for this. And look, I haven't seen any evidence for high FiO2s preventing nausea or vomiting. Hey, but if that's the thing, if you've seen some papers on that, that's great. Next one we've got here is an urgent PEDS case. So imagine, again, you're in a center where you just have to crack on with this. You have appropriate expert staff with you, or a buddy, a GPA buddy who's working with you, and together you're happy to do this case, backing each other up. The 4-year-old boy, forearm abscess for an incision and drainage. Let's say you're happy to go ahead with this case. The 20 kilos. What are the numbers you calculate? Like, do people have these numbers kind of in their memory, or have a checklist or kind of notes on this? I might just go ahead and tell you these numbers. Feel free to take a screenshot of that. That's the IM sucks dose. These days, I almost never use an uncuffed tube, so take away 0.5 for a cuffed tube. I always check the depth, because it's just so important not to endobronchially intubate these patients. And then the LMA package has the size of LMA depending on the weight. So for this patient, they're in the 2 to 2.5 range. I'll generally go larger than smaller. And then I absolutely have these things all written down and maybe drawn up in certain situations. If I'm not familiar with the environment, if I'm less experienced and haven't done PEDS for a while and I'm just a bit rusty, I'd absolutely draw most of these things up, especially atropine and the succinylmethonium IM, and always have propofol and spare normal saline just so you can flush things through. You're absolutely right. There's an app for this. And I've got to say, I like just having this in my memory. I get into work, there's a PEDS case, I write these down. It's there on on a piece of paper so everyone can see it. These are a couple of the other things. So, in this case, these are my numbers. I also just have these numbers going. I'm going to take a screenshot, but again, just look up any app for these. Now, what I used to think as I'm doing these cases, I'm not a specialized PEDS anaesthetist, but I do enough PEDS cases that the way I think about PEDS cases is, what could possibly go horribly wrong? What do you guys think? Like, what are the common things that happen in PEDS cases, and therefore, how do we prepare for that? Has anyone done kind of PEDS cases recently?
I can answer this one. So I guess the things I worry about most in pediatric cases, particularly, the things that come to mind are airway-related issues, particularly laryngospasm, because kids are at increased propensity to do so. In addition to vagal stimuli causing significant bradycardia, which also isn't too great for pediatric cases as well.
Yeah, absolutely. So you're absolutely right about the laryngospasm, and that's why. So, what is your method for treating laryngospasm?
So declare it early, 100% O2, but making sure that you're getting help in the room, having propofol and sucks drawn up and ready, but you'd be starting with your positive pressure ventilation first. If that's not working, then deepening the anaesthetic by giving them more propofol. But ultimately, if that's unsuccessful, then you'd be giving them succinylmethonium, proceeding to intubation, especially if the sats are dropping very rapidly.
Fantastic. I like what you said about the bradycardia. So what I've outlined here, I find that the airways can just be tricky because they're smaller and a bit annoying. But the great thing is that almost every PEDS case I have, you're just able to ventilate them. Like they just don't have the saggy tissues that older patients have. So practice, technique, lots of equipment, all measured up, and assistance. Hypoxemia, absolutely got to treat with all of those methods. But then hypoxemia often leads to bradycardias, and that's why we have atropine ready to give at the right dose, and then laryngospasm, as you mentioned, remove the trigger, obviously get help, CPAP, 100% oxygen, propofol, and eventually sucks. There's been one time when the stats had dropped so quickly that I didn't even bother with propofol. I just went straight to sucks. Remove the trigger, oxygen on, CPAP on, sucks given, because wasting time with the propofol may have meant that the stats got even lower. And so that's that. That's about 9:15, Greg. Are people happy to do a couple more scenarios on things?
Yeah, we've got a bit more.
Yeah, beautiful. Hey, so I've got. I think the one thing I really learned from my final exam, which I thought would be really useful for you guys, is the critical inductions. So there's a whole bunch of critical cardiovascular and respiratory inductions, and I thought we'd go through hypovolemic shock and one of the valves, because they are kind of the common things that come up and the common things that you might be presented with. So you get this hypovolemic shock situation. Again, you're in a center, you've got a 30-year-old 100-kilogram male having a motor vehicle accident, blood pressure is 80, heart rate is 140. Let's say they estimate 2 to 3 liters of blood loss for this patient. They're rushed into theatre for laparotomy for a suspected intra-abdominal vessel rupture. Now, you know all the general plans. This will be a GA, it'll be a rapid sequence, it'll be an intubation. What's your medication, and you'll have an outline as well, what's your medication balance and system for induction? Does anyone want to just kind of talk through this situation?
I'm happy to have a crack at it. I don't know exactly, but my feeling is that you would go heavy on the analgesia and very light on the propofol. Just super gently, super slow. Mm-hmm. You don't care if his heart rate goes, but you just care if his blood pressure drops further. And you try and resuscitate him, obviously, as best you can before you induce him at all.
Yeah, and look, there's so many different answers to this. What 100 kilo, 30-year-old male, 3 liters blood loss. These are your numbers. Give me some doses, like just rough doses.
So I think he'd need more than that. He'd need 1 to 2 mics per kilo of fentanyl, I reckon. And then I might give him 30 milligrams or something and see what happened.
Yep. And that's good. And then you give it like a rapid acting muscle relaxant. That's really fair. So everyone's got a different method for this. Now, I go just, a small dose of ketamine, some midazolam, rocuronium, and no propofol, and some token fentanyl. And my aim is I don't care too much about tachycardias and pain. I just want this patient to sleep, and I want their heart rate still buzzing really fast to keep the circulation going. But also metaraminal rhyme, because as soon as I give any of these drugs, doesn't matter how cardiostable ketamine is, in this situation, it is a negative inotrope and it drops the blood pressure, even though I've given nothing. But you're absolutely right. I would, if I had propofol and that's the one I was giving, I'd absolutely give like 3 mils of it or 2 mils and see what happened. I find that midaz is just so stable that I can give 3 midaz and nothing happens, and they close their eyes in these situations as well. Fluid and blood running, absolutely. And my aim is absolutely maintaining that preload and that afterload with aramine and not giving much of anything. And then I just want to keep that heart rate super high. So, giving some pain with a laryngoscope, I don't care about, as long as they're amnestic. That's really good. So, lower everything and support the blood pressure, preload and afterload. The valves, there's a whole section you can do on all the valves, but the common one is aortic stenosis. So let's say you have a 9-year-old male, 60 kilos, for a fractured neck of femur, and they're from a nursing home. They've got advanced dementia. They're not for resus, but these patients are in a lot of pain, and that you just can't have routine bed care with a fractured hip. So they need essentially a palliative operation for pain management. Let's say they've had a transthoracic echo 3 years ago, showed aortic stenosis that was really severe, valve area 0.8 square centimeters. What's your induction for a dynamic hip screw? Let's say because of the severity of the aortic stenosis, you're going to do a GA, not a spinal. Let's say that's just the culture of what you do. What would be your dosing for this? Anyone can jump in.
So I can give it a shot. Is this somebody that you'd be quite gentle with your induction agents, as in almost half the dose of what you give in a sort of middle-aged adult? So for me, I would use fentanyl and propofol. So fentanyl, I would probably go maybe 50 mics of fentanyl, 25 to 50, but I'll go 50 for this. And then propofol, I'll run a TEVA, but I'll start, instead of starting at, say, usually 7 to 8 mics per hour, I'll probably start at, say, 4 or 5, titrate to effect, and then do a GA with a tube. So muscle relaxant wise, I'll probably use rocuronium, and I'll use 0.6 milligrams per kilo. Just to mention with the propofol, probably, if I was giving it as a bolus, I'd probably give it slow, just because in elderly patients, they're quite sensitive to it. And I think the other thing for this guy is probably to do a block, so you can do a fasciitis block.
That's good.
Just to reduce the propofol requirement.
With your, let's say we're going to talk aims, and your method is totally reasonable. Everyone will have a different set of drugs and different thing, but I feel like your goals and your endpoints are the most important thing. What kind of heart rate range are you aiming at? Do you want low, like normal, or high heart rate?
You would like to aim for a low normal heart rate because he's got a history of aortic stenosis.
Yep. So you want lots of diastolic filling and coronary perfusion, and you want to decrease the work of the heart. What kind of blood pressure? Do you want normal, high, or low?
You'll be aiming for, I would say, normal.
That's fair, and that's not a wrong answer. Most people would aim for a high one because you've got such a thick myocardium and you want as much coronary perfusion pressure as possible. And you want to maintain preload as well. So with my, GA, absolutely, ETT, IV outline. And my induction for this is actually quite heavy with fentanyl. I really don't want a tachycardia, so I'd rather give 50, 50, 50 of fentanyl. I often give this patient anywhere from 100 to 200, and depending, like I'm giving 50 while I'm there doing the outline, giving another 50. I keep titrating it up. And I've got to say, I give 1 to 3 of Medaz, and they're completely out. And I just give the rocuronium. I might give a bit of propofol. I'll slowly increase the volatile, bag mask the patient, get their volatile levels up. Everything's really slow. I've got aramine running. That drug helps to get the blood pressure up and the heart rate down. And then I put the tube in very, very, in a relaxed fashion. I'm not rushing in to do that. But I do use a rapid acting muscle relaxant because I absolutely want good oxygenation the whole time. This is just an example of, the high-risk induction sounds similar, like a lot of people talk about cardiac inductions and often confuse a cardiac failure patient versus a hypovolemic shock patient versus other kinds of patients. So the aims are really important for this, because then you realize like the difference between each of the pathologies. I've got a whole, this might be like an hour, 1 to 2 hour talk on all the different critical inductions in more exhaustive detail. You could probably just Google, on my YouTube channel, just search critical inductions and you'll see this talk. And yeah, that's actually it for this talk. I know we've gone a bit over time, sorry about that. But if anyone have any questions, and look, I'd really appreciate any feedback, what worked, what didn't work. Just fill out the QR code there. And just let me know how it went. I really do try to improve these lectures based on your feedback. And please do it now, because I never do feedback if I move away from the screen.
Terrific. I'm going to put one in, Lahira. I like to think about position of the patient too when we're planning. So like whether it's lithotomy or prone or lateral, where the arms are on by their side. Do you agree with that? It's an important early decision.
And I kept on thinking where I'm going to add that. Like as soon as you have a gynae case, gynae surgeons often want the arms in. And so as soon as I've got the drip in, often I'll put the drip in the QB fossa just to have that little bit of access there. Or if the drip's down there, I'll have two extension lines already ready to go, like one aramine and another one for injections. I don't want to be flushing stuff from up here and waiting for it to get to the hand. But absolutely.
But even the simple stuff, if it's right-handed surgery, make sure you put the cannula in the left. I mean, just don't make these silly mistakes that we all do. Get them out of the way early, and reminders.
Absolutely.
Anyone else? Well, we've got the QR anyway. Thanks, Lahira. That was great, and it's fine to go over. This is core material. We could have done it earlier in the year, but that's good. Thank you, and everybody, if you can, we'll see you next week for Lachlan Rathie. And excellent.
Fantastic.
All right.
Yeah, his book is so interesting as a read. So anyone who hasn't got it, definitely worth a read.
Yeah.
Thanks, guys. Now, what's new with AB Students of Anaesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anaesthetic journey, from medical student to procedural skills, from foundations in anaesthesia, as well as really important exam lectures and clinical anaesthesia courses as well.